Well, hello again. Our guest today is Dr. Harry Jacobson, who has just recently retired as the Vice Chancellor for Medical Affairs at Vanderbilt University Medical Center. But Harry, you've got an amazing background. When I looked into your biography, you're a medical doctor, you're an academician, you're a former administrator of a multi-billion-dollar academic institution and medical center. You're a corporate entrepreneur. You started and created a multi-billion-dollar corporation. You serve on multiple boards of directors, both large and small. How in the world have you managed to accomplish the task of balancing all these careers?
Yeah, well, the secret is, Turney, I'm actually 100 years old. No, I generally pursue those things that I really like, that are interesting, and when I do, I find the energy and time to devote to them. But don't forget, like you know, we've had long careers, and all of this didn't happen at one time. It was sequential. And actually, one message I give to young people is, you know, don't be impatient. Your current opportunity, your current situation is not the last one. There are going to be many, many more that come down the road, and that's really happened with my life.
Sure. Well, that's great advice. Well, I tell you, Harry, let's just focus on one career at a time. Let's begin at the beginning. I think you began your career as a medical doctor. You were trained as a nephrologist, if I'm not mistaken, or a kidney specialist, perhaps in layman's terms. I think we're all watching with some alarm the growth in the epidemic rates of obesity and diabetes. There's a lot of talk about the cost of care for those patients growing in the years ahead. What's wrong with obesity and diabetes in this country, and what can we do about it?
Yeah, well, a larger and larger component of our healthcare expenses are in the management of chronic illnesses that come from, many of them come from bad behavior, and certainly obesity is one that is fixable, but you have to intervene early. But we do have an epidemic of obesity and diabetes, and they are responsible for a lot of end-stage diseases like hypertension, like diabetes, like kidney failure. And what we really need to do is understand that in this country, while we have great healthcare delivery, we've underinvested in things like education and prevention. And one of the things we have to get more serious about, and that means we have to develop mechanisms and ways to pay for it, is to really intervene early on and do a much better job in prevention and in education.
Of course, the U.S. healthcare system has been designed to promote that very thing. It was a fee-for-service system that encouraged doctors to charge per event, not to be rewarded for prevention of events. Do you see the possibility that we'll ever be able to change the culture in this country, particularly in the healthcare industry, to address the very kinds of things you're talking about?
Yeah. Well, we may get into this in our further discussion, but if we talk about healthcare reform, but one of the things that you need several things in order to address that issue of prevention. You certainly need to have changes in reimbursement so that there are financial incentives. You may also need some efforts on the part of employers to provide not only incentives but also disincentives for certain kinds of behavior. And then you need to develop the delivery infrastructure to actually deliver on prevention. We know an awful lot now. There's a lot of medical literature, a lot of good evidence about things that work. We just don't deploy them. So there's a big gap between what we know and what we do today in the area of prevention.
Let me go back to your biography, if I might. So we started with the beginning of your career as a medical doctor, a physician, and then you became a teacher of other medical doctors. You became a professor. How did you make that transition, and why did you make that transition?
Yeah, that's a good question. I think most young people that decide that they want to be doctors do so because they actually want to hands-on take care of patients. And then along the way things happen. In my case, it was really around mentors, and both in medical school and during my residency training at Johns Hopkins, I had mentors who really were very successful, very influential leaders in the field, my field, the kidney field, and were professors. They taught, they took care of patients, they also did research. So those role models really were the ones that pulled me away from finishing my training and practice to take care of patients to actually stay in the academic setting and become a teacher and researcher.
And then after a period of time, Harry, you transitioned again from being a professor in a medical school to being an administrator, ultimately to being the vice chancellor for medical affairs at Vanderbilt University, which is one of the premier teaching hospitals in the United States, one of the leading academic medical institutions in the United States. I wonder how did you make that transition? How did you manage to succeed to the extent that you did in transitioning the perception of Vanderbilt from an institution where people were reluctant to be treated because they were afraid they'd be treated by young doctors to an institution that became the gold standard perhaps in this community?
Yeah. Well, I never intended to be an administrator running a medical center. When I was a young professor in a medical school, I thought maybe one day I might become chairman of a department of medicine. So it was pretty much a surprise. And actually what happened was that the University of Chicago recruited me and asked me if I would take a look at being the head of that medical center. And in the process of looking at that position, I got the idea, maybe I can do this. And so instead of going to Chicago, I ended up, because of Joe Wyatt and the succession planning at Vanderbilt, in having the opportunity to lead that medical center. At that time, Vanderbilt's was a very good medical institution. Probably people didn't know as much about it and all the good things that were going on there. And so one of my jobs was really to get the message out. So we worked very hard at letting people know what we do. And also what's happened in the last 15, 20 years is that from consumer surveys, we learned that people really now equate excellent care with being taken care of in an institution that's doing research. So we actually leveraged off of that and let people know that if you want the latest and the best in technology and in ideas and in treatments, that an academic medical center is the place to go. So it was branding, it was marketing, but the other thing we did was really aggressively recruit hundreds of new physicians, people who wanted their career to be at a medical center, but they wanted to take care of patients. And so the critical mass of caregivers really helped Vanderbilt attract patients.
And then somewhere along the way, you also became an entrepreneur because you were a co-founder of Renal Care Group, I believe. I assume your interest in Renal Care Group came from your background as a nephrologist. That became a multi-billion-dollar corporation, perhaps. I know it's been sold in recent years. Tell us about that experience, and how did you have time to be an entrepreneur while you were still running at an academic medical center?
Well, I actually, with Sam Brooks and actually Dr. Ray Hakim, we co-founded Renal Care Group, so we worked together as a team. We really started in earnest in 1995. So that was when I was still on the faculty, but not heading up the medical center. And it's a lot easier if you're not in the senior administration to be involved in starting up companies in an academic institution than it is when you're in the top position. So we started it then, but it obviously grew to be a very large company. Fortunately, we had a great management team. I was the chairman of the board until I became the vice chancellor for health affairs, and then I just remained as a director of the company. And I was involved in strategy and vision, but the very, very good team of executives were responsible for leading that company and making it successful. And we grew it from a $75 million a year company to something just around $1.6 billion in annual revenues. And as you said, we sold it in 2006 to a much, much larger global dialysis company called Fresenius.
But your days as an entrepreneur weren't over yet. You have continued to invest in early stage healthcare companies. I think today you're one of the principals in the TriStar Ventures Fund. You may be involved in other private equity fund ventures. Tell us about TriStar Technology Fund. I believe it's one of the 10 Invesco funds, TNINVESCO funds. What is that program started by the state of Tennessee, and why did you get involved with that program?
Right. So since I, as you called it, retired from Vanderbilt, I've decided that the 35 plus years I've been in medicine and in healthcare and in research and science, that I would use that to look for innovative companies to invest in. And the Tennessee Invesco program really is an initiative that has two purposes. The state made available funds through the sale of insurance tax credits initially to 6 and now to 10 investment groups. And these funds are to be used to invest in companies that are headquartered in Tennessee or have the majority of their employees in Tennessee. So it's both an effort to get a return on some of Tennessee's money, but it's also an economic development initiative. And now there are 10 Invesco funds. Each has roughly $15 million to invest. So there's $150 million of new capital, largely for very early stage companies in Tennessee. And so this is a very important initiative. It's a great new program. Hopefully something like this will grow, because part of economic development is not just retaining the companies you have or inviting companies that are headquartered elsewhere to come to Tennessee. It's growing your own. Sure. And that's basically what we're doing.
Let's go back to our previous brief discussion about healthcare reform, and let's talk about the Obama administration's healthcare reform legislation. We've all read a lot about what's wrong or what's right with healthcare reform. All you have to do is to go on the internet and read the trustees report for the Centers for Medicare Services to see what a catastrophe lies ahead in terms of cost in this country. Tell us about your view of the health reform legislation. Was it good or bad? Tell us about what you think needs to be done now to fix the healthcare system in the United States.
Well, this show
and do all of that in about 5 minutes.
Yeah, the show isn't long enough to do that. But let me say, I think that we missed an opportunity to do some things with healthcare reform that I think would have set the stage for better controlling those costs. There are some good features of healthcare reform. Certainly, it is well-intentioned. So no one is questioning people's intentions. It's really, you know, what is the best approach to getting the results that we need? And we all know we've got a problem with the cost in healthcare. We also have a problem with the quality of healthcare. And the healthcare reform we recently passed is really largely insurance reform. It's really largely working out how do we pay for healthcare. And it doesn't address the question of what are we buying. And fundamentally, that's a question that needs to be answered, and that's what healthcare needs to do, and that is change what we're buying. And we need to buy much more evidence-based care. We need to pay for the things that we know work, and do the right things and only the right things. And if we do that, we'll right-size the cost of healthcare. So what we needed are some things that really change provider behavior, and in some case change patient behavior. And that will require more than just changing the way in which we pay. It has to change the rules around payment. It has to change what we pay for. And as you mentioned earlier, the reimbursement approach to healthcare in this country is largely paying for piecework. And if you pay for piecework and you change what you pay, if you reduce what you pay, the tendency is to get more work. And so volume times price is what the overall cost is. And what we really need to do is make sure that the volume is right and that we pay for the things that evidence says we should do.
Now, this term evidence-based medicine is a term that perhaps many of us have heard but may not totally understand. As I understand the concept of evidence-based medicine, doctors don't always do the procedure that's proven to be the best and most efficient or perhaps most effective procedure. Why is that? Why don't doctors always do the smartest thing?
Right. Well, if you answer that question, it really gives you the roadmap for how you want to reform healthcare. If you look at healthcare, it's largely evidence-based decision making. Every day, millions of decisions are made across the country in healthcare. Do I write this prescription? Do I order this test? Should I send my patient to see a specialist? Should I admit the patient to the hospital to treat this illness? Should I do this surgical procedure? Is this patient a candidate for having this kind of screening test? It's all about decisions. And medical research over the last several decades has generated so much knowledge to answer those questions that any single doctor can't, in this computer, hold all that knowledge. And so what we need to do is provide doctors and other caregivers, nurse practitioners, whoever the caregivers are, we need to provide them with that knowledge at the point of care. And that means using information technology to support decision making, because it's all about making the right decision at the right time. And it has to be at that right time. You can't say, well, let me do this test, and then later find out, well, it was the wrong test, so let me do this other test, because you just wasted time and you wasted money. So you need to make the right decision the first time. And that's really the research, the tools and the knowledge that we've created over the last several decades are very powerful. It's applying them correctly where we have the problem. And as we generate more and more knowledge, the caregivers are going to need even more support, because they can't, you can't anymore learn in your training as a student and as a resident or as a nurse or a nurse practitioner. You can't retain everything you need to know, and you can't carry a textbook around with you. So what you really need is point-of-care decision support, and the technology is available to do that today.
You're a doctor, not a lawyer, but there was a lot of talk during the debate about healthcare reform that we should also reform tort. We should have tort reform in this country. Many doctors say one of the reasons that healthcare is so inefficient is because it's necessary for them to protect themselves legally, to order excess tests and excess procedures. What's your view of tort reform in this country?
Yeah. Well, number one, I agree that we need tort reform. But number two, I don't accept the fact that it is a major, major contributor to the increased cost of health care. So it's convenient for people to use that as an excuse, but the fundamental thing is that we aren't making the best decisions. And so, yes, we have plenty of examples of problems with our legal system, and we do need tort reform. But if people are looking at that as the big driver for saving money in healthcare, they're going to be disappointed.
Harry, I remember visiting in your office on a number of occasions, and I was always so impressed with how quiet your office was. Not only the administrative assistants who were working outside your office worked very quietly in a very quiet environment, but when I came into your office, it was just a very peaceful place, and your style is a very quiet, soft-spoken style. Despite that, you ran multi-billion-dollar entities. You're a fascinating example of an entrepreneur who has done dynamic things. How in the world have you managed to do that as a soft-spoken executive when other people feel the need to be so loud and brash and high-powered?
Well, you know, I must tell you, I think genetics plays a role in that, because my father was always very soft-spoken, but you learn to listen to him. But he was always very calm, and sometimes I actually thought he was too calm. So people have always told me, you know, you're very calm. I've never seen you angry or, you know, shouting at anybody. That's just what I inherited, and that's the way I live my life.
What's going on inside? Are you in turmoil inside?
I'm not in turmoil inside, actually. You know, so I don't have ulcers, and I don't have hypertension. Even while I do a lot of things, and I am competitive at times, I'm pretty calm.
I know you're a man of faith, and you don't seem to be embarrassed about saying that. Thank you for that. After I came to Lipscomb, we founded the Hilton and Sally Dean Institute for Corporate Governance and Integrity in an attempt to provide conversations of significance about our U.S. business culture. We've read so many headlines in recent years about frauds and criminals and all the bad things that take place in U.S. business. What's your view of our U.S. business culture? What's your view of integrity in business in this country, and what can we do about it?
Yeah. Well, you know, there is no shortage of examples of bad behavior, but I think there are two issues here, and they're somewhat related. I believe there's been a lot of literature, a lot of research on the science of management, but I think governance is a very, very important and not as well studied and not as well taught and not as well practiced discipline. And I think if you look at a lot of what we see as examples of bad behavior, both in the for-profit and not-for-profit world, I think you can sometimes, or many times, and maybe even most times, trace it back to a failure of governance. And so I think boards of directors need to play a much more important role and understand that they have a responsibility not only in picking top management, but also in holding them accountable. And in order to do that, they have to sometimes be a bit more vocal, a bit more intrusive, a bit more analyzing about what's going on. Now, even if you did that well, that isn't always going to keep someone who's inclined to do something that's fraudulent or of, you know, low integrity. You might not be able to stop that, but I think you can definitely improve from where we are today.
When we first began the interview, I introduced you as the retired Vice Chancellor for Medical Affairs. I strongly suspect the word retired and the name Harry Jacobson don't really belong in the same sentence together. So tell me about your personal life and how you spend your time out of the office. What do you do to relax, and what advice would you give the rest of us who probably need to slow down and smell the roses a little bit also?
Yeah. Well, I think if you asked my wife, she would tell you I need to slow down and smell the roses a bit more than I am and that I have. Well, right now, my time is my own more than it was when I was heading up the Vanderbilt Medical Center. And so I have a bit more flexibility in my schedule. But I'm working, I consider it full-time, in looking at making investments in innovative healthcare companies. and I enjoy that a lot. It's basically doing full-time what I had the opportunity to do part-time through the earlier part of my career. But we are fortunate enough to have a vacation home in Hilton Head, so we spend time there. I love to golf. I try to do that every weekend. Now that my evenings are more free because I don't have all the entertainment responsibility of my position at Vanderbilt, the evenings are open, and so spend much more time with Jan, my wife, and with our kids and grandchildren. So I think it's my work-life balance is better now than it's been in a long time.
Good for you. Good for you. Harry, when I was an investment banker, one of my mentors taught me that the last question you should ask in due diligence is, if I had only known to ask you, what would I have asked you? And so I'd like to close with that question. What's on your heart? This interview is going to be seen by students, perhaps by others in the community. What do you wish I had asked you?
Gee, I think you've done a pretty good job of asking me. But you know, since this is an institution that's based on faith, you know, one thing we didn't talk about is that, and I think you're correct that you know, that faith is an important part of my life and my family's life. Thankfully, my wife has such strong faith that she pulls me along. But I think the most important thing I would say is that if a firm foundation in your faith in God is essential, and I would definitely say I wouldn't be here today talking to you about the things that have happened in my life if there wasn't a plan there from God, who has a plan for all of us.
Dr. Harry Jacobson, thank you for coming to Lipscomb today. Thank you for speaking to our students. Our guest today has been Dr. Harry Jacobson, former Vice Chancellor for Medical Affairs at Vanderbilt University Medical Center. We hope you'll join us again soon. Thank you.